Welcome to this web symposium organized by Seud, the Society of Endometriosis and Uterine Disorders. The title is very innovative because it is related to what we are doing now in this period, is COVID-19 and women's health. We arranged this symposium with three major speakers, worldwide well-known speakers, the best we have at this moment in the world. They are well connected, two from Spain and one from Canada. We will give, each of the speakers will give a lecture of 20 minutes, and at the end of the three lectures, we will have a question and answer discussion session. So everybody is welcome to answer questions. Now we have at the beginning of the session, we have a common question for everybody, for all the people who is in the audience. Did your hospital or center require the diagnostic test for COVID to all patients during this period of time? Because this is maybe different in different parts of the world. In Italy, for example, we are doing a test for any patients coming to the hospital for any treatment in OBGYN. So I think this may be universal question for everybody. After you do the answer, I can tell you that now the situation in Europe, in Italy, where I live, is much better than a few months ago. We are going out of this the critical period, and so the situation in our clinic, for example, is open now. Or at least we are continuing to do diagnostic tests for the patients incoming, but we are much more relaxed than few weeks ago when we interrupted all the surgeries. We did only oncology and obstetrics, so it was a real critical time, and most of our time was devoted to pregnant women and delivery and babies. So unfortunately, we had very few positive pregnant women for COVID-19. So this was a very good point of discussion, why pregnant women have less sensitivity in comparison to flu or to SARS, which are common viruses during winter time. But the COVID-19 was not affected many pregnant women. So now I think we are open for the discussion. And for starting the first lecture, 55% of worldwide hospitals still require a diagnostic test, while 45%. So the difference is not impressive like we are doing now in Italy. But this is important to understand how it was the different reaction all over the world in the different parts of the world. And now we move to the first great speaker, who is Francisco Paco Carmona from the University of Barcelona. And we start with a major starting point is how COVID-19 and reproductive disorders, uterine disorders, in honor of our society, endometriosis and uterine disorders. So Paco, 20 minutes for your lecture.
Thank you, Felice. And thank you, Seud, and for inviting me to participate in this event. As Felice told you, I will try to answer how is the relationship between COVID-19, the new coronavirus, and the reproductive system. There are not so much time from the last Christmas when we were all happy all over the world, and if somebody told us something about what we are going to live in the next weeks, in the next months, for sure, we will be sure that it was not real. Nowadays, we have more than 9 million people infected all over the world, and it's expected that the next week we have more than 10 million people infected all over the world, and probably we will have more than 500,000 of dead people for this new coronavirus. In Spain, things are like in Italy. We are a little bit after you, Felice, but I agree with you. It seems that things now are improving. it seems that we are now going out of this nightmare, but we need to be very careful. We need to be very, very prepared, because there are new focus of outbreaks all over the world, in Beijing, in Europe, in Spain. And we need to know things. We need to know what we have learned about this disease, about the pathophysiology of the disease, and the effect on the virus on the reproductive system. And probably I will give you some data, Felice, that maybe will help us to answer your questions. You know that the virus enters the cell through a receptor, to a cellular receptor, the ACE2 receptor, and it is the reason because at the beginning of the pandemics, at the beginning of the disease, there were some concerns about the effect of the non-steroidal anti-inflammatory drugs and other antihypertensive drugs, the possibility that those drugs may impair the course of the disease. This receptor, the ACE2 receptor, is very present. Is present in our reproductive system, in both male and female reproductive system. And we know also that the disease, the COVID-19, is a very inflammatory disease. It carries a systemic inflammatory response that's with a high secretion, a very high secretion of cytokines, has been called cytokine storm. And also the coagulation system is impaired, is activated in this disease, and the risk of intravascular coagulation and thrombotic phenomena all around the body can be present. And those things may arise some concerns in our patients with endometriosis, for example, because the endometriosis is an inflammatory disease. You know it very well. There's also a high secretion of cytokines, and there is a strong concern about how the relationship of the anti-inflammatory disease that carries also changes in the coagulation system. That, for example, it is a recent paper from the Shanghai's group, showing that all the coagulation system is activated in patients with endometriosis. We have shown something similar in patients with the Sungoi Guo's group, who was working with endometriomas. Where in this paper we showed also that the level of microparticles that are inductors of the coagulation cascade, of the coagulation system, are increased in patients with deep endometriosis. For sure, your endometriosis patients has called your office asking, may I use non-steroidal anti-inflammatory drugs? At the beginning, during March, I have to make just a YouTube video for the patients, just trying to keep their calm, because they were very worried about those points that I have shown you in this picture. But nowadays we have learned that we can rely on the use of anti-inflammatory drugs because they are safe for patients with COVID-19. It is very important. The hormonal therapy, the contraceptive therapy, the endometriosis therapy, the postmenopausal therapy can be continued, should be continued, and very important, the withdrawal of these hormones may accelerate the COVID-19 course, and it is very important. I will try to explain you why that happens. In this slide, I'm showing you how has been the impact comparing among sex in Europe. You can see that the number of cases have been more or less the same in different countries of Europe, but the number of hospitalizations and the severity of the illness has been much serious, much bigger in male than in female. And that difference is much more important in young patients than in old patients. It is the same study that you showed before. This study coming from China, coming from Wuhan, that the womb of the pandemics, clearly showed that the probability of hospitalization among women, among postmenopausal women, is bigger than in premenopausal women. And in these patients, in those patients with COVID-19, in premenopausal patients, the level of the cytokines in the more ill patients, more severe ill patients, is clearly related with the level of estradiol. As much higher the estradiol, lower the level of cytokines. It doesn't matter which cytokine you are studying. In all the cases, that there is a negative relationship between the level of estradiol and the level of cytokines, between the level of estradiol and the severity of the disease. And some people have also suggested that the estradiol can be a drug to use during the disease. And it is important, is the androgen. There is the androgen receptor, which is very related with the disease. You know that the activation of the androgen receptor may stimulate the secretion of the TMPREC2 gene that in turn may prime the human ACE2 receptor, that is the door for entering the virus in the body. And the spike of the virus is also primed by this receptor. So the androgen may be an important factor for having the disease and for the severity of the disease. In fact, in this slide, you can see how the activity of the androgen receptor is related with the severity and the viral load of the disease. And this is a very recent publication on Science with in men with prostate cancer, that when they are on anti-androgen therapy, the rate, the prevalence, the incidence of the disease is much lower than when they are not on this kind of therapy. So, keeping all those theoretical things in mind, let me now go to the more practical points. When the world was locked down, we had immediate consequences for our lives, for the lives of our patients, for our daily work. There were no outpatient visits, no elective surgical procedures. The emergency rooms were oversaturated. It is the example in my hospital in the day 0 of the lockdown. We were doing more than 600 visits, outpatient visits per week. We have more than 100 ultrasound studies per week. And 2 weeks after, we were completely closed. The hospital was almost only devoted to the COVID-19 patients. It was the same for the surgical procedures, from almost more than 20 surgical slots per week during the week. We in a couple of weeks we were in 1-2 slots per week. And what we did in those circumstances, the first thing that we did was to try to close and to cancel the visits. You can see here that it was the number of visits per week in the neurology unit that we were performing during February, around 100 visits per week, including the first visit and the consecutive visits. And we changed it, and we start to perform a lot of using telehealth resources. During this time, the only telehealth resource that we have had is the phone. We have made a lot of visits per phone, around 75% of our visits nowadays, that we have finally recovered the level of visits per week that we had before the pandemics. But we have changed. Only 25% of the visits are face-to-face. And what is very interesting, that when we have increased the number of visits per week, we have this means that our resolution capacity, we were able to solve most problems at the beginning, just to, okay, you may continue with the timing, you must change the timing. At the beginning, probably because we selected just a few patients, maybe the more serious, maybe the more easy, I don't know. We are trying to study and to publish it, because we decide to apply a protocol for selecting which visits can be done by phone or not, or by face-to-face. We are trying to analyze why we are able to complete the visit and not to make another appointment for a couple of weeks, face-to-face appointment in a couple of weeks, only in the 70% of the visits. Following with the practice points, you can use for your patients painkillers, the standard painkillers, the standard treatment that you were using before, paracetamol, non-steroidal anti-inflammatory drugs. Be careful with the contraindications that you know, asthma, kidney diseases. You must use the opioids carefully, and there are no need to stop the hormonal treatment for our patients. If that we have learned from our experience, if the treatment works, you can recommend your patients to continue with the treatment. If it does not work, you may change it. Maybe you can try to increase the progestin dose, but you have to change the treatment you are giving to the patient. And you can start, if you had to start a new treatment, you can do it as indicated during your daily clinical practice, your habitual clinical practice. You can use POP, you can use combined hormonal contraceptives. Remember the contraindications. Remember that there is not any special contraindication for this kind of treatment during this time, during the COVID time. Remember that postmenopausal patients, they have a more risk of having the disease, so probably the analogs are not the best option for our patients. And if you have to choose a new progestin for a new patient, remember the mechanism of action of those drugs, of the progestins, and remember that what I explained you before about the levels of estradiol and the androgen activity. So my recommendation, it is not based on any, I have not scientific evidence for recommending it, but if you take in account how the progestins work and the importance of the androgen receptor in the COVID-19, my recommendation should be use an anti-androgenic progestin, maybe Dienogest. It induces a very hypoandrogenic status that can be even increased if you add a small amount of estradiol that may also increase the level of the binding globulin, the sexual binding globulin, the concentration in the blood. Recommend your patients to use self-management of the pain and the disease strategies, education through the nurses of your unit, to the web. Recommend physical activity, maybe in home or maybe outdoors, yoga, physiotherapy, diet. Also try to start therapies focus on the emotions, and the surgery for sure. Sonny will speak after me, will explain much better, but you have to postpone the surgical procedures, and this is our numbers. We are now almost arriving to the number of surgeries we had before the pandemics. And just to conclude, our patients with reproductive disorders with endometriosis and other reproductive disorders, maybe the polycystic ovary can be another question, but in in general, they are not a high risk for COVID. You have no need to change the hormonal treatment. You have no need to stop the painkillers. You have to start new treatment. My recommendation is to start using antiandrogenic progestin like Genogest, and use freely and very with confidence the telehealth, and indicate surgery only very sparingly. Try to, in those days, not to perform elective surgeries. Thank you for the attention, and I'm open for questions. I don't know, Felice, if now or later, when you consider.
Thank you very much, Paco. You are absolutely in time. 2 minutes before the end, so congratulations. Very good time. And very good presentation. I like it, and I share most of your options. We had the same data, the same management of endometriosis in the hospital. In Italy, we follow almost the same guidelines, the same management. And now, before to start the question, because we'll be at the end, we have Sonny. Now, in Canada, it's 12 o'clock. It's noon. Sonny is almost noon. And Sonny Singh is the one of the most well-known minimally invasive surgeon in the world, and he will give us the how it's going in Canada, in Ottawa, during this period of time. So, Sonny, 20 minutes to you.
So we're going to go ahead and chat about what the status of surgery is. These are my disclosures, but of course, everything that we're going to talk about today is my own opinion as well. My goal is going to be to discuss the impact of COVID-19 on our gynecology patients, specifically the surgical patients, and then list the strategies for safer surgery during the pandemic, and define some of the challenges that have attacked us as a specialty and the access to care, which has been a problem as well. So, who knew that we were going to be in this situation when we were back in March? And you see my staff, as we opened up our first large testing center in my city with smiles and ready to prepare to test, but we didn't really realize how bad it was going to be. And then just within a week later, things got very serious as we started to see numbers creep up and situation change very quickly, not just locally, but globally. This virus, which in the past we take for granted viral issues and thought of them as historical issues, led to direct concerns on our practices. And more specifically, as was discussed by Paco, we had all elective surgery that was put on hold in our city as of March 16th. So 3 months of canceled gynecologic surgeries. And really the challenge there was that we had to define what was elective, what could wait, how do we decide? And the stress that we encountered during this time was significant. More importantly, the personal protective equipment issue became big. This mask that I'm wearing there was provided to me by one of my patients, and she made this for us because we didn't even know if we were going to have enough resources to do the activity we were going to do. Luckily, we started to see larger societies and some direction, not just locally as we built our own strategy, but the American College of Surgeons in the US was a fantastic resource for us. And we used a lot of this information to help guide us as to what is considered an emergency versus what would be perhaps considered something that could be waiting. And I think the most important thing for us as benign gynecologic surgeons, for the most part, is the fact that fibroid surgery and endometriosis-related surgery really was considered elective. Now, having said that, there are, of course, cases where you have to go ahead with surgery sooner. And the most profound things we were seeing were obviously abnormal uterine bleeding, and on top of the usual emergencies like torsion and ectopic pregnancy. But we had to now suddenly triage a lot better. We weren't alone, and I think this is the important aspect of what's happened in the COVID situation. So there's a group called COVID Surge. It's a collaborative out of the UK, which is an international collaborative, and published recently in the British Journal of Surgery, estimating that about 28 million surgeries worldwide were going to be canceled or postponed. And so we are one fraction of all of those other surgeries, to put it into context. For us, about 10% of the surgeries are gynecologic, so 2.5 million surgeries worldwide. In my own hospital, we had 500 surgeries canceled for gynecology and about 2,500 surgeries overall, a large part of that being actually under ophthalmology and other services that were high volume. So suddenly we were put on stop. What do we do for 3 months? And it was a time of introspection, reflection, and I hope people made it through in a healthier way. And this is actually a photo from my own garden, because I had to take that time to stop and pause to make sure we decided on what was important. And smelling the roses, as we would say, or the flowers, was very important to reassess what we valued. So Paco's already talked about this, that we actually managed in the same way, using telemedicine, many of our patients with endometriosis, fibroids, abnormal bleeding, through telemedicine, and then decided who would go forward with it. But very clearly there was huge benefit. I even had a physiotherapist doing telemedicine with me, because there's lots of education. And actually, doing a lot of chronic pain as I do, a lot of the education about what is pain, how to manage pain, and the video online resources, which I shared through my Facebook and Twitter sites, I would encourage you to share as well. It forces us to pause and rethink. I'd encourage you to look at other resources. In Canada, we have the CanSage website, so cansage.org/online, and we've held several online webinars similar to this one, and that one was specific to managing pain for pain and endometriosis during COVID, what other resources there are, and also we did one on abnormal bleeding. So there were strategies which I found very helpful. I'm not going to go through the details because it's already been managed, but definitely there's another publication in Human Reproduction Update, which I believe Felice is actually an editor of, published this recently. So they're all available online access. But the other thing we got to talk about is the fact that we had to think about how to work with our family. And that's my wife cutting my hair, my son, I had to teach him how to wash my car, very important. But please remember, as surgeons and as care providers, the only thing that we have that supports us in our background is our family. A recent paper in I believe it was JAMA Surgery, asked surgeons who are in retirement, what was the most important thing that you would have done differently? And most said they would have spent more time with their family. It wasn't to operate more, it wasn't to make more money. So during this time, remember to ground yourself and take care of yourself, because the surgery will always be there, but the family is what is important. Now, I do want to talk about the kinds of cases that we continue to do. So I was operating at almost once a week because I provide emergency service for my hospital for gynecology. And so we did placenta accreta type cases. We have a surgical obstetrics team that I help lead. And so those cases are not going to stop. Tubal ovarian abscesses. We did actually a couple of cases of torsion, ovarian torsion in pregnancy, one at 24 weeks and one at 34 weeks. And in fact, one of them was COVID positive. Severe anemia was really the profound thing. So when I looked to Felice and the Society of Endometriosis and Uterine Disorders, it became apparent that endometriosis has a large burden, but the acute problems really came from the fibroids, the anemia that needs to be managed aggressively, whether it would be iron replacement, medical therapy, but then ultimately surgery was really the one that took me to the OR most often. My endometriosis type emergencies were ruptured endometriomas, or we had a bowel obstruction that I had to manage as well. So we were kept busy. And this is, again, a plug for the placenta accreta cases, which I try to advocate every time to make sure this is a uterine disorder unlike any other that this society and group is acknowledging now. And this is in our privy. The skill set that we have to operate and deal with these conditions is very important. And this poor patient didn't have any family who could come into hospital, no visitors allowed, pregnant during COVID, and here I am doing a hysterectomy on her because that's what she needed to do. Now let's move to the more common things that you're interested in as well, which is laparoscopy, but with a safety twist as well. So we continued to do laparoscopy. And the reason we felt comfortable is by reviewing the literature at that point for the best that we had a international consensus statement put out with the AAGL as one of the leads to say that if you are going to do surgery during COVID or any time, what can you do to be safe? Well, first of all, we know, as was mentioned, that the RNA virus is small, and we need to know that it's been found in all sorts of secretions. And so anything that aerosolizes that, any activity that would create droplets that can transfer, might lead to infection in a healthcare provider as well. So that's my fellows who are modeling their N95 face masks with their shields during one of the first COVID positive patients we operated on. I've operated on quite a few now. And the N95 masks can filter out a large number of those particles, but being very careful and knowing what you need to do to be ready as well. And I think it's very important that we sit down and review what it is you need to use. And not every patient during the pandemic needs an N95 mask. If you've tested them and they're negative, please save that mask for another case where you need it. In fact, in my hospital, they're all under lock and key, and you can only access an N95 when the appropriate indication is there. And of course, the face shield and everything else that we would use as well. So know what is available and how you would use it. The first the first case we did in the pandemic, the patients were likely negative, but this was the very first surgery when the pandemic opened up and we had to do emergency cases. And my anesthetists were working on how to limit the spread of aerosolization during the most dangerous part, which is intubation. And so we had makeshift covers. And in fact, now we actually intubate in a different room, negative pressure room, and then transfer the patient over. I'm well away during the intubation to protect myself and my team. And we enter once the patient has been put asleep, and then we exit before they're extubated if we suspect that they have COVID or are COVID positive. In the joint statement, we talk about strategies like using the lowest pressure possible, minimizing any leaking through the ports, minimizing the number of times your instruments are going in and out. And please use smoke evacuation with the ultra low particulate filter. Make sure you know what filter you have. I found out that many surgeons don't know what kind of filter they have and that they aren't always using filters. So please do that. This just makes common sense. And in fact, the rest of the recommendations were common sense recommendations. So to avoid using a sudden release of CO2, how many times in our specialty do our poor residents or medical students or colleagues get sprayed with blood or fluid? You got to be smart. Pause at the end and limit that spray. At the end of the case, you want to evacuate all the carbon dioxide using the smoke evacuation system manually until everything is deflated, and then remove the ports. But do not vent the pneumoperitoneum into the room. It's very important that we protect everybody as we do this. My final recommendation overall is just be prepared, and there are no shortcuts. This is not the time for complacency. Be vigilant, follow your local rules, and be a role model for each other. Simple things like washing your hands, wearing the mask, which I'm in the hospital now, so I have to be wearing it. This is not the time to be an individual, but rather be a team player. Learn about what kind of access you have and learn how to work with the system and how to communicate. So in the final 8 minutes, I'm going to go over a couple of real-world examples of cases which we operated on that were impacted by COVID. So the first one is a patient who was admitted for a full week on internal medicine with the presumption that she may have COVID. She had fever, she was unwell, and she was tested 3 times during that time, which came back negative. And her fever was quite bad. She was tested for all sorts of other infectious causes. Finally, on the 5th or 6th day, they consulted our team and they said, this patient has a history of endometriosis. She was on Dynagest in her previous country, has been off of it for a year. do you think this could be causing her fever? And as anybody knows, infected endometriomas exist. And in fact, that's what she had. So the COVID situation delayed her care because of the chasing the COVID diagnosis and other things, where she really did have a surgical and medical emergency infected endometrioma. And you can see the pus there and everything being stuck. And at the end, we have our uterus, which has been cleaned up, and the ovary is removed there completely. And she got immediately better and was home within a couple of days, resolved. So lots of confusion everywhere and lots of understanding that's needed, that our patients' care is being delayed as well. And we need to act on these things as well in a positive way. One thing that's very important is, remember, at home, you need to make sure that your patients are safe. We know there's been an increase in violence, of intimate partner violence, and children who are escaping to go to school from abusive homes are stuck at those homes. So that's one other thing I always get stressed about and want to make sure I encourage us to talk about for our providers. The second case is an interesting case of a patient who had a miscarriage right in the middle of COVID. She has a DNC and she goes home. She comes back in April and is admitted with fever, pain, and bleeding, and the diagnosis is endometritis with a retained products of conception. Now, if you look at her diagnosis that continued after additional imaging, they now said that she had interstitial pregnancy, an interstitial ectopic. And so she was given multi-dose methotrexate, and then an MRI confirmed that, and then she was discharged. Well, I heard that story and I was quite concerned, because she was referred to me after all of this. And I saw her MRI and I got quite nervous. And I said, I need to bring you in. You may rupture this ectopic. I think surgery is indicated. Now, when she was brought into my hospital, she had a temperature of 39 degrees Celsius, and I diagnosed her with septic endometritis. My bias was still thinking about the endometritis that had been diagnosed on the DNC. And there's our interstitial pregnancy. The surgery has been done, and it was difficult diagnosis because the uterus was stuck to the anterior abdominal wall. But the thing is, things aren't that simple. So just like this lady trying to escape out of one fiery building, she jumps to her saviors and she gets caught into another situation. So the same thing happened. This patient was actually COVID positive. And if you go back in the middle of a pandemic, you realize that her fever and her runny nose that she said was due to allergies was not necessarily an endometritis alone, but it was actually the COVID situation. So I operated on her being a COVID positive patient. Luckily, we have a very good safety checklist we've developed. And my resident, after she saw the patient, said, Dr. Singh, she has symptoms. We have to treat her like a possible COVID patient. And because we talked to our whole team, we enacted all the right things to do. So we intubated her in a different room. We all wore N95 masks with face shields, and we followed all the rules because she was what we call COVID category 4, symptomatic, awaiting a test result, and we followed all the rules. So I was saved because my resident knew to screen her and did everything right. So please screen everybody, ask those questions, and think about COVID and be on the safe side. Because that patient who was positive, now I have to go back and look at the other hospital she was admitted at, all the nurses, the doctors, the patients she saw at home, how many people that would affect, and how many people we now have to contact. But it was my resident who saved the day. The fact that she asked that question, she actually did not wear the face shield when she first saw the patient in emergency. So she had to isolate herself for 2 weeks from her own family. She just had a young child. She had 2 children, and she had to miss work. She had to come off our call schedule. And then the consequences of all that stress are significant. So don't take anything lightly during this time and be super safe. And our doctors from Italy would tell us the same. Hundreds of Italian doctors dead, and healthcare workers have been affected. And I think the most important thing that I'm hearing from them is be safe, be smart, and be organized. You cannot take this lightly. Now, one of the things that comes up when I think about this, here I was in the OR and we're all anxious about this. I'm going home to my wife and my family. My wife actually put me into my own bedroom with my own bathroom on my own for the time of COVID because I was seeing emergency patients. So I was feeling isolated. But you need to take care of yourself. Exercise, be active, work with each other to create a system of social support, and do whatever it takes to reduce your stress as well.
Thank you very much.
Oh,
no, go ahead. Go ahead.
I have 2 minutes. Now we're going to reopening, and what we're going to do is do the guided ethical principles for reopening, Felice. I think it's important to people to know that we want to balance what we're going to be doing. And we have to think differently. So you are compassionate about your own patient, but make sure that you think about the bigger picture. So in my own system, we're trying to make sure the patient who needs to be done is done at the right time by the right person, and that it's not only done by myself. We have a team that's created a committee where we organize and we look at the cases, and then we prioritize based on what's needed rather than what we think is needed. And my final slide is simply that we need to look at how many cases there are of COVID, what the hospital capacity is, what kind of equipment we have before we open. But we are heading to the right direction, and we will open soon. And we need to be smart because this is not going to go away. We can't just cover our eyes. We need to cover our faces. And so I might leave you with a simple message to be safe, be strong, and be smart during this very difficult time. Thank you very much for including me.
Absolutely. Thanks, Sonny. You were in perfectly in time, 20 minutes again. And again, we agree because the lockdown was simple. In all the countries, lockdown. Now, how to restart is the problem. And this is an issue for each government, believe me, because even in Europe, in a small continent like we are, different countries, they have different decisions. The government, the politicians say different opinion on the restarting. So when will be the elective? So we change. But again, as I mentioned before with Paco, we are in a good phase in Western Europe. So we hope to open now to this elective surgery, and we are starting again to have almost a regular activities. No, thanks very much, Sonny. It was very nice. The one topic which I would like to discuss later with you and all the speakers is the stress in providers and patients. This is an issue we had all the time, and we still have. So, but before we have to listen Juan Antonio Garcia Velasco, one of the most worldwide famous IVF infertility assisted reproductive technology. He works in Abbvie in Madrid and at Juan Carlos I. So Juan, 20 minutes for your lecture on assisted reproductive technology at the time of COVID.
So as I said, I'm going to try to give a different perspective based mainly on ART treatments, and most of what has been done is going to help me also to support the same message, because I think even from different perspectives, we all have and had to face the same problem. First of all, I just want to mention that this is what we know today, and with this virus, I think we have all witnessed how things have changed so quickly, and what we were doing in March, then we didn't do in April, and then maybe we are not doing in June. So be cautious with interpretation, and as this changes quickly, and use, as mentioned today, recent evidence, up-to-date data, and of course common sense. That is what we mainly use. The impact of the disease was amazingly unexpected, and this is data from my country, and the number of people infected and hospitalized, and the deaths was just shocking. And this is more or less the phase that we had when things became very serious. It was mentioned just now by Singh, and we had a similar situation. This picture, I'm sure you know, it is the picture of the first boy who had a cochlear implant. So this is the first time in his life that he was listening to sounds. It's a mixture of emotions. He's shocked, happy, and scared at the same time. And this is more or less the phase that we had, I think, when we were in the hospitals looking at these hundreds of patients just coming, and we were completely lost on how to manage these patients. In our area, and infertility was easier because we stopped, and of course this virus affected our our patients. It was explained also by Paco Carmona in the first lecture. It's mainly affecting males, but also affects females, and you can see in purple. And even though it mainly affected older women, if you look at the age strata, you can see how women from 25 to 50 also did get affected, and this is our main target patient population. The lockdown was impressive. I think we have lived something that we will be telling our grandsons and granddaughters. We will never see pictures of our cities like this again, but it reflected just a desperate social isolation. We had nothing else to do, just stay home, don't move, try to minimize your movement and the risk of spreading the virus across the city. And obviously, if you stay home, you reduce viral reproduction, you prevent healthcare system collapse, as it happened, at least in my country, and you're going to contribute to the reduction of morbidity and mortality. So what happened with IVF and ART? What did the scientific societies say, Esri and SRM and SEF? They just mainly said, stop new treatments. When things got really scary, we stopped everything, ovulation induction, IUI, IVF, and of course, non-urgent gamete freezing. We canceled embryo transfer because at that time we had no idea about the impact of this virus on the pregnancy and malformations, miscarriage. And we just finished those cycles that were in between. Takes just one extra week and finish that. And of course, we stopped elective surgeries, as mentioned just now by Sonny. The issue was, what do you consider elective? And this was, of course, a discussion, but this was what we had to plan. Most of these recommendations were based on the daily increase of the cases. It was rapidly increasing, on the impact of the virus on both patient health, but also on our employees. Our staff was at risk of getting infected by moving in the city, by taking public transportation, and of course in the clinic. And also because of this not known impact of the virus in fertility and on the pregnancy itself and on the transmission patterns. It was extremely quickly, mid-March, some recommendations were given. ESRA, SRM, and the Spanish Fertility Society, they all at mid-March say, stop, it's not prudent to keep doing these treatments. And then you can see here, end of April, still not agreement between different societies. And this was very interesting because whereas the European Society suggested to restart the ART treatments by May or in April, ASRM, the American Society, is still considered not prudent. And the reason is quite simple. This virus affected geographical areas in the world at different times. So when we had to close our clinics and hospitals in Spain, I had some discussions with colleagues from the other part of the world, and they were considered that we were too dramatic. Why are you closing the clinics? You can still continue treatments. When we started to recover and the virus hit America, North and South, then these colleagues understood very well that the only reason to get over this is to minimize the work, stop anything that is not elective, and then you will recover quicker. This is what happened in particular in our clinics. Look at the number of cases today. This was shown by Paco again. Before, we have had in Spain 250,000 cases already around the world. And sorry for the mistake there. It's almost 10 million cases, so something very impressive. You can see at the end of January, in Spain, we had the first case, end of January. Just a few cases at the end of February, and we were just being cautious with patients. We see a lot of patients from Italy in our centers in Italy, so we were just cautious. We just had 2 days later, 10 cases. 2 days later, 33 cases, so we stopped to transfer embryos here at the end of February. And then suddenly things exploded, and we had the first COVID death in our country was in beginning of March. But then suddenly things went crazy, and as you can see, the number of cases exploded. In just 2 weeks, we had more than 5,000 cases in the country, and that's when we decided to stop, and the state of alarm was declared. This is, as you can see in these lines, what happened. Mid-March, we stopped everything, and you can see at the end of March, 23 March, we were doing 0 cases of any treatment as all of us. Why did we do this? I mean, why did we stop treatments? Because there was no legal obligation. The law did not say you have to stop, because actually, infertility is a disease, it's not an elective treatment. It was only based on recommendations from scientific societies, which are not regulatory bodies, they just suggest what to do. And this was a very interesting decision, and I think it was based on risk mitigation. The situation was so critical in the country that people couldn't move across the cities easily or travel across different cities. Both patients and staff were recommended to stay home. So, and in fact, the situation was so critical that both of our ventilators that we have in our clinic in Madrid were given to public hospitals because the situation was very, very critical. What is the impact of this on ART? This virus may affect different tissues. As you know, the angiotensin converting enzyme, as explained by Paco, is the door of entry for the virus in our bodies, but there's no evidence that this virus is present in the oocytes or in the sperm, and here we have some discussion later, not in the embryos, follicular fluid, or uterine or vaginal secretion. So this provides quite a reassurance to continue after this pandemic, the treatments. But data keeps changing continually. This is one of the best reviews on the impact of COVID on pregnancy. And we were at rest when we read that pregnant women do not seem to have high risk to develop the severe form of diseases. They do not seem to have more miscarriage or early pregnancy losses or more malformations. And of course, this is based on a few hundred cases that have been published so far. I'm sure papers will come most likely from China with thousands of patients and larger experience. It doesn't seem that pneumonia is more frequent in pregnant women than in general population. However, this is, again, just a few hundred cases. So due to the lack of data, we have to keep our eyes open and follow closely the recommendations from scientific societies. This is a very interesting case, a report from the New England Journal of Medicine published in April. And you see that 215 pregnant women attending a hospital, this is hospital in New York, presented for delivery. You can see that 1 in 8 is positive. And of course, symptomatic patients are PCR positive. This is when you detect the PCR easily. But some of them, in the days before, they're still asymptomatic and they can test positive. And this is the main issue. 1 in 8 is not a low number. But how do we restart? How do we bring our patients back now that the situation is significantly much better? Life has to continue, and this is a picture from Vietnam where they seem to have no cases or very few cases, and people want to go out again and resume visiting friends and family and going out for dinner and going for holidays. I think we have to be aware that some things have changed with this, and before we move on with our daily life, I think technology has changed our lives already. I think telework, as mentioned by both previous speakers, Paco and Sonny, I think telework is here and is here to stay. I know when you talk to patients, they mainly prefer face-to-face consultation, but they minimize the number of face-to-face consultations today. They can do a lot of things by platforms like Teams or Skype, telephone, email, many things that used to be a visit now can be done with the help of technology. And this can only get better than where we are today. This is going to have an impact on the economy. I think we are worried about this, and this was the front page of The Economist a few weeks ago. They talk about the 90% economy. It seems that this year is going to have a huge impact on works and on unemployment. And of course, if there is no money and less taxpayers, the governments will be in trouble to fund health, or people will be in trouble to pay for the insurance or for the treatments. The stay home was very effective at that time, but this is, I think, very, very much linked to culture. And some countries live at home and some countries live on the street. And if you travel around the world, if you go to Southern Europe, and that's where we stay, Felice and Paco and myself, people live on the street. People go out continuously to see friends and to see family and to have a drink on the bars, or to go to the movies. And some of the countries like Northern Europe, they feel they stay much more time at home. They don't move that much. And I think this had a huge impact on how the virus behaved around the world. And then they have, I'm sorry for the Spanish here, but there's one point which is fear. This is what this means. And still our patients fear to go out of the street. They fear going to the hospital because they think the virus is in the hospital, and they fear that they may get the disease when they interact with other people. And even though we have been open now for 3 weeks in our centers, we still see patients coming with surgical masks and double masks and face protection and shields and things that for them as patients probably is not necessary. But still, this is an issue that we will need to solve, because staying home for such a long period that we are not used to that, people feel so secure at home that they have fear of going out of this shelter, of this shell. So we are here to think what to do and how to do things, but we have to do things. We cannot just keep discussing with webinars and writing protocols and papers. We have to move on and do things. So we have to take data from how we can detect the virus and how we can test patients and staff. We're all familiar with this very nice graph from JAMA from last month. And safety is priority number one. We have to mitigate the risk in patients and staff. We have to get used to social distancing, physical distances, with at least in this part of the world is not very common. Sanitizing surfaces, testing, documenting testing, PPEs, I mean, all the things that we all know today. When we started 3 weeks ago, we were extremely severe with this. We confirmed the booking by email. We suggested patients not to come, of course, if they were symptomatic. I'm talking about the fertility clinic here. So if patients had symptoms, we tell them to stay home. Come without your partner, with no family. Come on time, not too early and not too late. We didn't want to have people in the waiting rooms. Wear a face mask. If not, we will provide you with one. And we had to give a letter of appointment because people were stopped on the street by the traffic police because they were moving the city. Which confirmed by SMS. Once they came to the clinic, there was a nurse doing a triage with the conventional issues. Maximum 2 patients waiting. If not, they couldn't enter the clinic, and we suggested to use the stairs, no lift, because of this. And this was a small circuit. They went through the triage. They were given new face masks, new gloves, hand sanitizer, temperature test. And then they would come in the clinic and say, this is the 1.5 meters mask, so they wouldn't go beyond that. And of course, we had these shields in front of the staff, of the reception desk. Everyone is wearing the mask, and everyone was not wearing clothes from home. Everyone changed in the clinic. This was the circuit. They would enter here, have the triage, go around, and then go through the reception desk. Once in the clinic, everyone was wearing scrubs, mask and gloves. Again, this is from the very beginning. The screens were in the front desk and also in the outpatient office, which was very strange for us as doctors to talk in front of a screen. Everything was electronic signature, even for consents, and everything that we could avoid spending time with the patient, because all of these consents were sent by mail. They could be sent, signed by the patient, and when they enter the clinic, they would spend just a couple of minutes with the secretaries and go to the consultation office. We treated all asymptomatic patients from 3 weeks onwards. Not if they had contact with COVID positive patients, not if they had themselves had COVID in the past 3 weeks, not if they had hypertension or any chronic disease like renal, respiratory, diabetes. What and how to test? Well, we were quite more stringent than the ESRE triage. This is what we're doing today, following just triage. But at the beginning, we were doing serology to every patient and PCR if negative. So we were testing every staff and every patient that came to the clinic, and we were doing PCR if IgG was negative. And if IgM or PCR was positive, we would cancel the stimulation and cancel the transfer. And we have data from this first series of patients from end of April until end of May. Only patients who were negative in the triage, so no symptoms, no fever, were tested for IgG, IgM, and PCR. And we had a very low incidence. Out of these 1,500 patients, only 3.8 were IgG positive, which is extremely low for such a contagious virus. Only 11 patients were developing immunity, and only 1 had a positive PCR. So it's difficult to justify universal screening for all the population when you have such a low incidence. I think the triage probably is good enough, and we can discuss this later, of course. And then, as I said, new data keeps coming. We have new data coming from placenta that they find the virus in some isolated cases. They found the virus in men who have severe crisis of the COVID. So this is not asymptomatic male. This is not male who recovered from the COVID. That there are several papers showing there's no virus in the sperm. This is patients who were really sick and they were asked for a semen sample. And just consider how sick they were, that some of them could not retrieve, could not collect a semen sample. So probably when you have this huge viral load in your body, virus is coming from all secretions. I won't mention more on the operating room because it was clearly mentioned by Dr. Singh just now. And in the labs, they use always level 2 labs. So the risk of contamination is extremely low. The way you work in an IVF process is by diluting and washing continuously, so minimizes the risk. We continue with the same temperature, asepsia, and positive pressure as always. Avoid all manual pipetting. Everything was mechanic. Obviously, microscopes were cleaned after each use per embryologist, and they were cleaned mainly with soap or alcohol. What else? Obviously, face shields with embryo transfer and blood analysis to avoid the sprays. And same thing for the staff. Do not come if you have symptoms. Avoid public transportation if you can. Discard masks and gloves when you arrive and get new ones, and only scrubs. These things relax a little bit. Now we are in phase 3, and we are not using gloves anymore. We are not testing patients, only triage, and if they have symptoms, we don't treat them, but we keep testing our staff. We had 20% of the staff was immunized, so that means that many of them got the disease. I personally went through the disease at the end of March. I think we got the disease in the clinic, and I was quite sick by the end of March. So obviously, I wanted to be tested and see that I was immune and could go back to work. Another fear that patients had is that by waiting, they could have an impact on their outcome. And this paper came out, published actually this week. These are patients who had to wait up to 180 days, and these are difficult patients, the diminished ovarian reserve patients. And if you look at the success rate, there was similar response and comparable pregnancy rate, so not an impact on the outcome. Finally, what did we learn? Well, I think social distancing, it's something that we learn, and it's a combination between the fear that someone in front of you may have the disease, or also a sign of respect that you are not going to contaminate anyone in front of you. It's like wearing a mask. I think this is just a sign of respect of the people that are near us. And always, obviously, you would have to trust what we always trusted, but I think this is going to stay. We work much slower now. We are less efficient, and maybe this is a good thing because we spend much more time with our patients. So maybe this is a good thing from this. We as professionals have to recommend anything based on data. I mean, we now have less doubt and we know more about the disease. And we should be ready for a hypothetical second wave. Obviously, we will be more proactive than we have been now. We know how to work from home now, so keep your teams, keep your computers, because we may use them in a few months, hope not too much. I think the staff has been trained to be multitasking. I think we all have done many different things that we didn't do before because there was less staff in the clinic. And keep some of your PPEs in the store because we had the severe difficulties to get them when the pandemic was hitting us. Thank you very much.
Thank you very much. I think also your lecture was very clear. We can be proud as gynecologists and reproductive medicine experts and minimal invasive, much more than microbiologists or virologists who had more panic. I think our approach all over the world, as you mentioned, also in pregnancy, in pregnant women, infertility clinic, assisted reproductive. I think we panic for some period, but now our results are really very reliable. And as you say, we hope not to have another wave, but if we have, we know how to approach. And we are progressively going toward the same less and less intensive management now. So I don't know how, if there are any questions from the audience. I will start just from you, Juan. You are one of the world experts also on cryopreservation. So cancer patients, do you think they should be treated like cancer patients for cryopreservation of gametes? or there is a different topic? Because it's very ethically, it's a very big discussion.
It is a good point for discussion, and I know that cancer patients, a lot of them are immune suppressed.
Sure.
And they could be facing a higher risk. But I think what we do in fertility preservation, freezing oocytes or freezing sperm, especially freezing oocytes, of course, which is more complicated, I'd say, than freezing sperm. I think they have to do it. I mean, they have to. They should do it. I don't think they shouldn't be scared of a treatment who takes about 10 days, who is not going to really complicate their lives. And if they want to freeze their oocytes, I don't think this would be a problem. The main problem is when you have the city completely collapsed, and then you have no ventilators in the IVF units, and then you have no slots, as Paco mentioned, to do retrievals. So the problem is that if it's a breast cancer, they can wait 3 weeks, okay. But if it's a lymphoma or leukemia, they cannot wait. So my suggestion in this particular question, which is should they freeze their oocytes, I think they should. And in fact, they have been one of the very few cases that have remained open for the time.
Yeah, no, because we read many publications in this period, but nothing on cryopreservation. So I was curious to listen. What is your opinion? And Sonny, you spoke about the healthcare providers versus patients' stress or risk mitigation. How is in the surgery room, in the theater, the situation between surgeons and nurses, for example? How is the relationship? So
it's a good question, because during the ramp up, so now we have, just to give you an example, we have 500 cases we have to catch up on. What are we going to do?
Exactly.
Plus, during that time, during all the telemedicine, I had another 100 cases to add or more. So now our hospital, we're going to work 3 shifts. We have a daytime shift, an evening shift, and weekend to operate, which is putting a stress on our teams, our doctors, nurses, our residents. So that is creating some anxiety and stress. And to be honest, I feel like we're trying to also catch up with system issues we had even before COVID. And the third thing, Juan mentioned this, I think, is the second wave is very serious in North America. The US currently is in certain states increasing numbers of positive cases we're seeing is making us nervous. We're trying to get through the backlog, thinking that by September we may have to shut down again. So you're right. It's a stressful environment, and all I recommend is that be patient. I've been meditating a lot more. I think everybody on this line should be meditating.
Absolutely.
To decrease your anxiety, your stress, your patients should, because we have to realize it's not about us. It's not about, it's about our patients and trying to support them. But the system is so much bigger than us, and we have to work together.
One question for you from the audience. How about hysteroscopy now? Is time to restart?
And no, excellent question. And in fact, our friends from the Global Congress of Hysteroscopy just put together a guideline, which I recommend. It's, I believe it's free, open access. And it talks about hysteroscopy is not a aerosolizing procedure on its own. Especially today, I'm doing a whole list of hysteroscopy. My outpatient unit is open today for the first time to help diagnose all those poor women who had postmenopausal bleeding. So it is time. We are being safe. I do wear a shield so I don't get any splash. But it is time. And I think doing it outside the OR, not in the operating room, is the best. If you don't have to you don't have to do those things. So I hope everybody is starting again.
Paco, there is one question for you, Paco. What about the risk of thoracic endometriosis in the incidence? Now that, this pneumonia, what do you think they can increase because of the...
Do you know that thoracic endometriosis, it has been stated at the beginning of the pandemic that patients with thoracic endometriosis may be a higher risk, but I don't think so. I don't think so. First, it is a very rare situation, and you have to differentiate between pleural or diaphragmatic endometriosis, that is one thing, and pulmonary endometriosis, that is another thing. And the most important risk factor is how is the pulmonary function of the lady, of the patient. And in general, the pulmonary function is not impaired in patients with thoracic endometriosis. Maybe in some cases of very severe pulmonary, not pleural endometriosis can be a risk factor. But I'm sure that it should be not a special danger or special fear for all patients with thoracic endometriosis.
Okay, good.
I have also a question for Sonny. Sonny, how you deal with the exhaustion of the team? People in the ward, the anesthesiologists, the nurses, has been devoted to the pandemics. While we were at home or just operating a few cases, we were the whole day in the first line, and now they are exhausted, and we are trying to recover at least part of the surgery that we miss, and they said, no, please, let me rest. How do you think that we can deal with this situation?
I'm glad you brought it up. I think as surgeons, we always talk about our own environment. We see the world through our own eyes. And I'm so glad that we're taking a pause to think about everybody else. So yes, it's our patient. We want to advocate for them, but we have to do it within the bigger context and understand there's so many other people involved. And I'm so glad you brought it up, because it may mean that more of our patients will be delayed, but it may mean that we will have healthier nurses, doctors, and providers who can do better care. So I think my only suggestion that we've done is we listen, we are trying to be patient and communicate. And every time I see a colleague, I thank them for doing the work they do. And then in our hospital, we focused on wellness. So we actually had a mindfulness challenge for all healthcare providers in the hospital to encourage some mental rest as well as physical rest. We did a walking challenge where we competed against each other to walk. We did a half marathon. We do whatever it takes to build a team, even though we're apart. But I'm glad you brought it up. I think too often we focus only on ourselves.
Sure.
We have to think about everybody. Thank you.
Thank you. Thank you. Now it's time to close the webinar. We are perfectly in time, 1 hour and 15 minutes. I wish to thank all of you, because I think our contribution in this field is fruitful, because we give when I was interviewed here in Italy, among the others, they said, oh, the obstetric gynecology is giving some good news. No, because we have a baby, there was no problem for the neonates, for the newborns. So in the medicine, in the general view of medicine, we are giving some good options for the fertility, as mentioned by Juan, in the minimally surgery in endometriosis. So I think it was good now to have this webinar from Seud. Seud is very involved in this benign situation, but very impacting the women's health and women's quality of life. So even though they are benign disorders, we impact on life of these women. So to have in a good situation in this period was good. We thank all of you for contributing to give this message from Seud, and we hope to at the beginning of November. You see from this slide, we will have an online week. Unfortunately, we cannot have the annual meeting in Stockholm in May. Was planned last May, but we will have an online week. We hope to have many of you will be free. For all the participants, we will have 2 hours a day. So it's very simple, but focus on the treatment, update on medical and surgical treatment on endometriosis uterine disorder. And I think it would be nice to have these 4 days of discussion, questions, and to continue the awareness of Seud on this topic for the health of women. Thank you again to all of you, and thanks to the organization of Seud and the contribution of all the sponsors. Thank you.
Thank you.
Thank you, everyone.
Bye-bye.
Nice weekend.
Yes, thank you.